From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to this JAMA Authors Podcast. I am Dr. Linda Brubaker, a JAMA Deputy Editor, and I'll be speaking with Dr. Emily Jungheim about uterus transplant. Dr. Jungheim is Professor and Chief of Reproductive Endocrinology and Infertility at Northwestern University and the Medical Director of Northwestern's Fertility and Reproductive Medicine Center. Thanks to you and your co-author, Dr. Jessica Walter, for contributing such an insightful editorial regarding the recently published article on uterus transplant by Testa and colleagues. In your editorial, you compare this innovation to the early days of IVF. Could you share your thoughts on that?
Lots of research and medical intervention in reproductive medicine has always been controversial, but particularly when IVF came about, there were lots of concerns about how it may impact pregnancy and outcomes for children, and lots of controversy. The first IVF center in Virginia, folks tried to shut it down, but they persevered, and now we're in a place where it's offered routinely to folks struggling with infertility. I don't know that uterus transplant has been advertised broadly, but I suspect as it catches on, we will hear similar controversy in the lay press and folks who have concerns about it.
Well, the complexities of care that make uterus transplant possible are significant, and this type of costly and complex care isn't widely available, as you mentioned. Could you talk with us about what you see as the broader availability in the near future?
As you mentioned, it is complex and it requires so many people with unique skill sets and lots of resources. But just as IVF, when it first started out, again, lots of resource, lots of skill sets between the basic sciences and the physicians involved. As we have more data in terms of the outcomes and how to make things effective and efficient, we'll see that the uptake is higher. Because at the end of the day, it's having a child, being a parent or not being a parent is a big part of many people's lives. And I think we'll see more people who want to pursue this option.
There are other uterus transplant cohorts across the globe, it's my understanding. Do you know if the success rates are similar, or what is your sense of the global status of this work?
I remember when I was a fellow back in 2005 going to a meeting in Boston where they were talking about uterine transplant. And at the time, it was really just talking about doing it experimentally in rhesus monkeys in other countries. And here we are now where there are multiple cohorts, as you mentioned. Again, I think initially it was just a case report here and there, but now we've got these cohorts that have been set up largely to collect data in experimental fashion, similar to the duets cohort that is in this manuscript that we're talking about, with the thought that's gone into planning these cohorts and getting information from folks who've had success. They are seeing a lot of good success with them. I'm sure many people will remember when Cleveland Clinic reported their first case and the patient had a rejection of her organs. Since that time, though, they're up and running and offering this procedure.
Well, the procedure is not without risks, both for the donor as well as the recipient, and so it's not something that should be entered into lightly. Could you comment on the magnitude of the risks and how people should approach their thinking about whether the procedure is worth the risk?
It's a tough one. This morning I was in seeing patients and we were talking about this complex mix of physiology, medicine, and sociology and desire to be a parent. And I think many folks who struggle with infertility would agree, and many parents would agree, that they would go to incredible lengths to have their children. So it's a very personal balance, I'd say. But in terms of the medical risks, pregnancy itself can be risky. And we see women with varying degrees of underlying morbidity and coexisting or pre-existing conditions who venture into pregnancy nowadays. So while it has some risks associated with it, as you can see from the paper, the outcomes were good and people had the outcomes they were looking for. I think what's tougher perhaps is the risks involved for living donors. A lot of times, at least initially, it would be known relatives who would do this. And we talk about gestational carriers in my practice all the time, and the risk of carrying a child for someone else, for example, is sometimes worth it because you get a niece or a nephew out of it as well. So there is something in it for you. In terms of where living donors might come from in this scenario, though, there are programs that are talking about using donors. As in this cohort, there were a couple of cadaveric donors, and that's different. But in terms of how successful those organ donations would be is yet to be seen, which is better, cadaveric or a living donor.
Well, let's turn to the outcomes in the children. And so far, as reported in the TESTA manuscript, the outcomes are reassuring. Are there any other concerns that would only show up in a longer timeline?
This harkens back to the questions that we had with early IVF children. It's hard to say, but the biggest risk we get concerned about is the risk of the immunosuppression during pregnancy. There are lots and lots of data out there from folks who are recipients of kidney donation, cardiac donation, et cetera, that have shown that these children are okay and do well. I guess the way I think about it overall is pregnancy is long and humans are pretty sturdy and resilient when it comes to exposure. And so looking to those other cohorts of folks who have had children successfully that have grown into healthy adults after being exposed to immunosuppression, I think we're going to be in good shape.
Could you talk a little bit more about what it is about the immunosuppression during pregnancy that might pose the risk for the children?
A lot of medications just aren't studied in pregnant women. So we just don't have a lot of data. Anytime we're talking about giving a pregnant woman a medication, we're balancing risks and benefits and then turning to small case studies to look at risk. And that's just tough. So a lot of it is just kind of this black box where we don't know what the potential outcome is until we have the data. But again, looking to those other cohorts that we have, by and large, it seems like we're going to be in good shape.
Well, in your practice, you're very aware of the sorrows and difficulties that infertility bring into the lives of affected individuals and families. You're very close to that. You hear those stories on a daily basis in your clinical world. You and Dr. Walter call for a shared vision of alleviating this suffering. What research and clinical activities need to follow this seminal report of uterus transplant?
I think what we're missing in reproductive medicine overall, when you look at the folks who question the risks and benefits and question the need for these types of treatments, I think the data we don't have to show them is how desired these outcomes are, how much of an impact in quality of life these interventions have. And so if we could do some well-designed quality of life studies, surveys for folks who go through these treatments and really understand how they impact long-term quality of life, I think that would be really, really helpful. Fertility treatments in general are still largely self-funded. Again, I think because there is question as to what the value of these procedures are and these treatments. But anybody who's seeing these patients on a daily basis, like you said, it's life-changing in a good way.
Well, thank you. This has been Dr. Linda Brubaker, a JAMA Deputy Editor, and I've been speaking with Dr. Emily Jungheim about uterus transplant. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you find your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thank you for listening.